During the 2016 American Academy of Ophthalmology meeting, Duke Eye Center held educational presentations in our exhibit booth. We hope you enjoy watching the faculty sharing the latest in ophthalmology.
So I would like to welcome everyone to the Duke Retina panel at the Academy, and I'm Tamer Mahmoud from the Duke Eye Center, and we have guests today, Dr. Yosuke Oshima from Osaka, Japan, and Dr. Carlos Mateo from Barcelona, Spain. And we have great cases, surgical cases today, and a lot of nice discussion, so hope you can enjoy the discussion. So we have different things to talk about, and the first thing we're gonna expand on macular holes, since we have so many options for macular holes nowadays. And before that, we could just go in and detach the hyaloid or peel the ILM, but nowadays we have all those options. So I'm gonna start with you, Carlos. When you look at all those options on the screen and you have a patient in your clinic with a macular hole, how do you decide? Take us through some of those options.
Yeah, let me tell you, first, ocriplasmy is not very popular here there in Europe. That we don't use too much ocriplasmy in very selected cases. Macular buckles are for high myopes with the posterior staphyloma mostly, and not in regular cases. The most important technique we use is ILM peeling, of course, and that way is very important for me, that you have to take into in mind that you have to peel the ILM, but how much you have to peel the ILM, because if you peel too much ILM, for example, you can have retinal problems or retinal disturbance, and we try to peel the ILM only one disc around the macular hole, and of course we use inverted flap in high-risk cases when the macular hole is larger, and in high myopes, for example, in recurrent cases we use the free flap.
Yosuke, how about you? How do you think about them?
Not yet the official approval. So we have the only way to do the vitrectomy, and the simple gas injection also not so popular. We have not yet have such a experience with confirmed efficiency. Actually, in simply use the conventional vitrectomy with arm peeling, we can achieve almost near to over 95% of the success rate to close the hole. So also we have standard surgical techniques to do the arm peeling in the case. And injection gas, we depend on if it's a very small hole, early stage of the macular hole, we simply inject in the air. And when it's a long-standing macular hole, we try to use the SF6 or something. If the case is even it's a very the primary macular hole, but it's still complicated with long axial lengths, we're still thinking about some background of myopia. So such a case, even the very simple hole that sometimes encounter the unclosure. So try to use much longer long-standing gas, for example, if the C3 fade or something. We will agree with Carlos, the macular buckle is not so popular for the simple macular hole, just only for the macular hole detachment in the high myopia cases.
Okay, so we're going to show one of those cases. So this is a patient that had trauma and had a macular hole. The ILM was already peeled, and you can see around the area of the macular hole the peel. He still had the edges up. We tried a gas bubble in the clinic, and it didn't close. So we were thinking of going in and trying to close that hole and doing a free ILM flap. You can see the area around the hole where it's already peeled. So what we're trying to do here is going in with the forceps and trying to get a piece of ILM so we can move it over the fovea. And some of those cases can be very tricky to try to position that over the hole. It's very thin, the ILM. And now that we obtained the ILM, you can see that it's nicely moved as a sheet over the hole. But look at the problems that we're having now. You have the ILM forceps, and the ILM forceps really sticks to the edges of the ILM. You're trying to free it. Ideally, we shouldn't be using a light pipe very close to the macula. Use another forceps and a chandelier. But this is what, we were able to at least put it in that area. And with very slow fluid air exchange, even on passive, we could keep that ILM in place, and it closed nicely. Functional improvement was not much. It's a free ILM flap, so you can see the center of the fovea, the area of gliosis. You don't see much retinal structure, but at least we were successful to close the hole. So the question that I have for you is, now that we have all those options, and one of them is the free ILM flap, what's your, if you can give me a tip or a trick, how you can keep it in place? Yosuke?
So basically, in such a case, I prefer use the peripheral column. I try to peel off the ILM underneath the peripheral column and just sliding We grasp the edge of the peel, the free flap, and grasping the flap edge, the shifting to the macular hole. So underneath the powerful carbon, much easier for you to control. Of course, before the injected powerful carbon, we stain the ILM with BBG or with the undercyanin green. We can stain the ILM. We can know how the location of the ILM. So even underneath the powerful carbon, very easy to control.
Carlos, any
I
tips?
use the same technique as Yusuke. The key point here is how big the perfluorocarbon liquid bubble you have to put there. Because if you put a small bubble, perhaps the ILM will be sticky to your forceps, and you are not able to remove it. Then you have to put perfluorocarbon liquid to mid periphery, and then you go there, and then it's very easy to bring down. But at the end, the point is when you're making the fluid exchange, and try to remove the fluid always the contrary where you don't want to move the ILM. If the ILM is moving to the temporal side, aspirate in the nasal side. If it goes to inferior, aspirate a little bit superior, trying to maintain. But at the end, our patients leave the OR walking, and then the patient face up. Then sometimes it's difficult to
And
maintain.
this is some of the problems. This is not a guarantee procedure that it's going to stay in place. One of the things that I used recently is using Viscoat.
Yeah.
Not the Pro Viscoat. It creates a bubble,
Yeah.
and it doesn't at least fly out. It stays within that bubble of Viscoat, and I can adjust some.
The original description, I think, from they were using viscoelastic material to maintain the flap there.
Not easy to inject the viscoelastic to maintain the bottom, because if the current, the infusion current makes strongly, we will
I
wash
think
out
it's easier
it.
nowadays with the valved cannulas, and especially not the
Yeah,
Pro
of course.
Visc, the
Of
Viscoat.
course, of course.
Yeah,
Yeah.
inject a
You
lot
can
of it,
choose
so.
the type of viscose, much more high viscosity.
I think
Carlos.
only a comment. Try to, for all the guys, try always to peel as less as possible. 1 this diameter is better. Just to, if the patient fails, you have the internal limiting membrane near from the hole.
So
you
that's
just
interesting
try
because
to-
some people used to say, "Oh, we want to have a wild ILM peel." Now, leave some, and you may use it. So
I think you have Dunfel's and other kind of problems in the inner retina. Retinal sensitivities decrease in the area of Dunfel's.
Yes.
I try to lower, to decrease the size.
Yeah,
of
depend
the
on the size of the case, of course. For example, the retinal attachment, the macular hole, you need to peel much wider to close the hole, because the high myopic case, the macular hole is not easy closure. But the very simple case, even if it's a little bit larger hole, I don't think that we need to peel off so wider up to the arcade. We just pick about, and not so small, just about 2 or 3, two
You don't need much.
diameters. Yeah.
But in my opinion, you are trying to obtain a secondary effect. You're trying to relax the borders of the hole, and you're trying to relax all of the retina in the staphyloma. That's why we are peeling more larger area.
Okay. Now we're going to continue with the same topic, and another option for those macular holes. So this is a very high myopic patients that I had multiple procedures outside Duke, and detachment, oil, came with eccentric fixation, and I was planning to get a free ILM flap, but when I went in, the ICG was pulling completely into the staphyloma. I couldn't get, so I thought I would get a piece of retina. So this is what I got. I went in the superior quadrant, I got a piece of retina, and then by manually I put PFC over the piece of retina so I can cover the hole. And then fill the eye all the way with PFC. I can adjust the transplant, that piece of retina in place. And the key was to do a direct PFC silicone oil exchange, so I make sure that I can keep it in place. Because of the staphyloma, sometimes you have small bubbles of PFC close to the transplant, so I was very careful so it doesn't move. And we published this, that we closed the hole, and so what? I mean, the hole didn't close. The transplant is the one that closed the hole. What was very exciting is that the vision improved, and the retina that we moved from the periphery started developing outer layers. And you can see here the changes of that retina gradually as the vision improves. But we also did co-localization with microperimetry to go exactly at the same area. And over the transplant, you see the gradual increase in sensitivity. And we also did multifocal ERG. So we've been doing, many of those cases now.
It's a full layer of the neurocentral retina. It's a
It's
fully.
a full thickness retina.
Okay.
The retina was already very thin when we moved it, but
Mhm.
gradually, when we moved it to the macular area, it
Mhm.
started thickening
Yeah.
and developing outer layers. So we started doing some of those cases,
Yeah.
and we're gonna see one case was Carlos did, and then we're gonna also discuss this.
Let me
Yeah.
make one point. This is my second case. My first case, I lose the retinal transplant, as I told you before, and this was a case that has been previously treated 3 times, and the patient had silicone oil in the eye, but macular hole open, very very large, the retina detached. The feature of these patients is the macular hole is larger and larger and larger, and silicone oil ends in the subretinal space. And then I decided to go inside to remove the silicone oil and to make this retinal transplant. I didn't have too much retina because the patient has treated 3 times and then a lot of laser in the periphery. But put the video, we'll see. This is the case, 3 times previously treated. I didn't take care about the perfluorocarbon liquid under the retina. I removed the silicone oil first. As you can see, it's a very big hole. Then I put perfluorocarbon liquid inside the eye. And then I decided to grab this. You can see all the periphery as full of laser. And then I decided to grasp the most peripheral retina I could. And then I cut with these 23 gauge scissors under perfluorocarbon liquid. I didn't do laser or diathermy in this case. And then, I cut a free flap of total retina. And then under perfluorocarbon liquid, I cut all this flap, as you can see here. Unfortunately, no bleeding in this case. And then with 2 forceps, you will see how I put the transplant just directly into the hole. And this was the technique, and I find it very easy in this case. And this is the aspect at the end of the surgery. I did laser, of course, around the peripheral break. I did laser, and this is the aspect the day after. But this is the aspect now after 3 months. You don't see the retinal transplant. You have some bubbles of perfluorocarbon liquid. This is the main problem. But as you can see here, you even don't see where is the cut of the retinal transplant. I had some bubbles, as I told you, perhaps were mine or perhaps were in the subretinal space, and I didn't take care about. For me it was striking how can be this, because I couldn't find the break between the previous retina and the retinal transplant.
I have the one technology question. You make the silicone oil, the perfluorocarbon direct exchange to avoid the missing the flap, right?
Yeah.
Okay.
It was this is the only retina that you had to work with because it was very close to the posterior pole. But if it is very close to the macula, why did you have to do laser at the area where you got the transplant from? Did you need the laser?
I don't know. I don't really know. If you put silicone oil, perhaps you don't need it. But it's a patient that has 3 previous retinal detachments, and I decided to lower
so
the
the
risk.
oil is still in?
So oil is still in.
Okay.
Yeah.
Are you gonna
this patient is
plan-
from outside of Spain. Then he
Okay.
has to come in. I think in 3 months, 6 months. Then I cannot tell you visual results on any. But this is the last 3 months later, and the patient was happy and.
Would you consider doing anything for that bubble of PFC?
I don't know. It depends on the patient. It depends on the vision. It depends on the vision. If the retina is attached, perhaps I will decide to remove the oil. Depends on the intraocular pressure, of course. But if there is good pressure and I decided, I will remove the bubble.
So did you change your surgical strategy than your previous thinking? Because you previously in the unclosed macular hole and high myopia case, you perform the macro backhoe.
No, but this patient is not a high macular.
Not high myopia.
This is not a patient with.
But if the case with high myopia, how do you treat that one?
No. Now the patients with high myopia and posterior staphyloma, I'm treating them with buccal.
Backhoe, not the transplantation.
But this is perhaps in the future I will try to do this in this kind of myopia.
Well, we have so many options to discuss, but we're going to go to the next topic and discuss some of the PDR surgeries. And some of the techniques developed over the years, delamination, segmentation, and now with the newer instrumentation that we have on board, all the different gauges, valve cannulas, cutting rates, and so on. So I would like to go through what's your preferred technique. So Yusuke, you have all those options here, and forceps, scissors.
Yeah.
How do you decide? What's your preferred technique?
Yeah, basically, my case, right now we use most of the 25, 27 gauge. It's very easy to simply use the cutter, but pray for play the several roles, just like not only the cutter, you can play just like the forceps or the pick, we can use only the cutter to play the several roles. So in my case, I basically like to the setting the chandelier, the bimanual technique, but I have less chance to use some complex instrument. Simply use the cutter, we can remove the vitreous and then the peeling off the membrane and separate the membrane from the retina, only simply use the cutter, can do that. Based on for my case, I mainly use the cutter and maybe additional use the instrument, the second instrument maybe the horizontal scissors. Otherwise, I have less chance to use other complex instrument for the case.
Great, Carlos.
That's great. I saw films on Yusuke and has amazing technique with 27 gauge. I continue to use 23 gauge in the most of my case, or 25 gauge, because for me, for example, aspiration, if you have to remove the posterior hyaloid in this high Maya with you will see in one case, it's so difficult to remove the vitreous, and the force you apply to detach the vitreous sometimes is not so good. Then it takes some time to remove the vitreous. Then I prefer to use 23 gauge. I use a lot of viscolamination because has two main advantages. First, you separate the tissue, and the second, if the patient bleeds, it maintains the bleeding down. It doesn't flow away, and prevents your visualization. Then viscoelastic material prevents this kind of massive bleeding, and I use a lot of viscolamination.
Yeah, so let's look at some of the techniques here. Yusuke, you have this case of your question was with buckle or consider a retinectomy and ILM peel. So why don't you go through that
So
case?
this is a case where a severe detachment case and with total detachment with a severe contraction of the membrane, but they already have the partial vitreal detachment. So just I don't think it's good for you the viscoelastic, because sometimes it misleading the viscoelastic to enter the retina. You may encounter much trouble, easy to remove it. So for my case, the indication for the viscoelastic technique is without any detachment, without rich detachment, but they have the very severe fiber membrane contraction without PVD. In that case, it's very easy to use the viscoelastic separated. For that case, I think it's very easy to perform use my manual technique to separate the membrane from the retina. In this case, we already perform very peripheral shaping. We can complete the induction of PVD and shaping the vitreous up to the peripheral area. So in that case, it would still have some very strong contraction, shrinkage of the retina. I think we don't need to perform the 360-degree encircling bond. We just need to perform partial retinectomy to releasing the retinal tangent. And in that case, most of the case, I also prefer you, just like in the video I show, I always perform the iron peeling. I like to remove the scaffold to prevent the secondary proliferation after the surgery. Because the surgery is the type of case, that sometimes we encounter very severe inflammation reaction after surgery. So after remove the ILM, I think we can reduce the chance to have the secondary proliferation.
So routinely in those cases now you peel ILM?
I peel ILM. Just like this case, the total detachment, I peel the ILM again underneath the peripheral carbon. I stain the ILM and put the peripheral carbon, flatten retina, and peel off the ILM just I show here.
So one of the things that was very interesting that you showed is that peripheral retinectomy. Because of the extensive contraction, you feel like you needed something, you don't have a buckle.
The key point in this case, I can create a PVD up to the peripheral area. I complete conduct the PVD, and only we can remove that, make sure we can perform the vitreal shaping as much as we can. Around the shrinkage area, there no longer the vitreous are adherent to the retina. That means we don't have so many tangential traction after surgery, because there are no vitreous adherent there. So that's the reason why small connected to flatten the retina much easier to attach the retina. In such a case, we use the 25 gauge. If it's to the encircling bond, we need to perform a 360-degree periectomy and do the encircling bond, increase much more inflammation. So for my first choice, in such a case, I perform the retinectomy.
And it seems, go ahead.
But if it's the case, we cannot completely perform the PVD, we still remain some portion with vitreous adherent there. I prefer perform the encircling bond.
Okay. Well, those retinectomies also in diabetics seem very different from the retinectomies in PVR cases where you need to have a large inferior one.
Sure.
So a localized one would work in diabetics.
That's a localized shrinkage. I prefer to use the retinectomy. So that's a very, very rare case. Only a very localized, very small shrinkage in the portion, because there's a long-standing contraction at this case, so it's not easy to flatten the retina, even if you remove the vitreous. But
Great.
if the case, we still remain a lot of the wide area of the vitreous cannot separate it, especially the nasal portion. We no need to make so aggressive induction of PVD because they will sometimes encounter much more severe macular breaks or something complication. So in this case, I prefer put the buckle to support the to eliminate the traction after
Great.
surgery.
So, Carlos, you have a case where you want to show us the viscodelamination. So,
These are two cases. This is a typical case with a very severe proliferative diabetic retinopathy. The key point here is if you use viscolamination, as Yusuke mentioned before, is to find the plane. You have to find the plane. This is the key point. You have to find the plane between the retina and the posterior hyaloid and the new vessels. And then I began to inject this viscoelastic material, opening, a space between the retina and the plane of the posterior hyaloid and the new vessel. Look at this. Hasn't been injected anti-VHF drug before, and look at this. The bleeding. Patient bleeds, but the bleeding stays there. Don't fly away, preventing good visualization. Have to remove the instruments. Then you can use, of course, both hands just to clean everything. And then you remove the blood over the retina, as you can see here. And I totally agree with Yusuke. I try to remove also I do diathermy in the stalk of the new vessels. I leave there just to prevent postoperative bleeding. And I always try to remove the interlimiting membrane. This is another case, the same, much more difficult. And this is the kind of case that is very difficult in my hands to remove the posterior vitreous with a small gauge. Here we are trying, there is a break there. We are trying to open a place to inject the viscoelastic material there, and then with both hands, then we are beginning to inject viscomaterial just to open this place, and then with the vitrectomy tip, we are going to, in the forceps, we are going to remove all of this tissue, as you can see here, and then we are progressively with the vitrectomy tip. This is wonderful also to detach the posterior hyaloid. You enter in the space and you inject a little bit more, and you will see how the retina and the posterior hyaloid, detaches. And then this is at the end of the dissection. We aspirate some fluid from the retina, but the posterior hyaloid in the periphery remains attached there. And for me, this is very difficult to perform under small gauge. And in this case, we went under air, and under air has some, advantages, and they began very slowly to detach the peripheral vitreous. You can see here. Under air, you can see the vitreous because of different refraction index. As you can see, we are aspirating and removing the vitreous towards the periphery. Be careful. As Yusuke said, you can promote breaks in the periphery. And then I always remove the internal limiting membrane, not because of the edema. I try to avoid that remaining areas of contraction affects the fovea. Remember that the ILM is who transmits traction in the retina because it's the, toughest part of the retina. Then for me, it's very important to remove the internal limiting membrane in these tough cases.
So Carlos, I always think of, PDR is I want to elevate and cut. I don't want to inject because I don't see. I don't know how the adhesions are. What are you using to inject?
What I am using, this is a Hava cannula. This is a special cannula to inject the viscoelastic
And
material.
how safe do you feel about pushing?
Believe me,
yeah.
you see it. You separate a little bit tissue. You see separated. You go to another direction, separate a little bit more. If you don't see it, just stop. Go to your vitrectomy tip. You cut it this. You find the way, and you cut it this, and you go injecting. And for me, it's a very, very, very safe.
Some ask me about the role of. I think this is one of the things about intraoperative OCT. So I think now especially with the newer generations of swept source, is going to help us see. So you would feel also more confident about where to inject and so on.
The problem is that so dense, and in some cases, so dense tissue will be difficult for the intraoperative OCT to see down and to separate the structures. Then I don't know. In so severe cases, I don't know.
Yes,
There are 2 key points in this thing. One is the injection instrument. Then it's I prefer use the instrument. It's a directional injector. You can adjust the curvature to insert into between the membrane and the retina. As previously, it's a commercial available from the Synaptics. And another one, as you said, we cannot make sure how wide or how deep we created the PVD during the case. So I prefer mixture with the dye. I make sure that because the viscoelastic material we use for the transparent. We cannot differentiate how wide or how wide we extended the separation. So I prefer to make sure with ICG or make sure with the BBG. So that reason why injected, we can make sure how wider we already separated the area.
Oh, that's
And
a great
different
idea.
colors, and also let you to make sure you miss it leading into the under the retina or just between the correct space between the retina and the vitreal space.
Now, one of the questions that we always have, a lot of physicians are injecting Avastin or anti-VEGF prior to bad diabetic vitrectomy, and if the patient is very sick or doesn't come for the procedure, you have worsening traction. So the question that they always ask, would you inject it routinely? When? How soon before the injection? Carlos?
I was injecting in every single case with very severe cases. Now injecting less and less. And with the VEGF drug, I use Avastin. Not in all cases, perhaps in 10% of my cases. How many days prior? I use 5 to 7. Believe me on that. In 2 days, you can treat all the VEGF drug, but the biological reaction that you need to avoid real bleeding, I think in my hands needs more time. Then I wait 5 days after injection. And how to deal with cancellation, this is the main problem. I tell the patient, if I inject, you have to assume that you have to be operated, or perhaps you will have a problem.
So
So as you know, we published a paper in the ophthalmology a couple years ago. We the first used the Avastin for the traction attachment case. At the time, I do much more, but right now I do a very less cases in that because because we encounter very severe complication in one case. It's a very young patient with a very severe ischemic case. So after injection, we lost the vision just 2 days after, or 1 week after surgery, or 1 week after injection. So it's a very severe caution as to if the case with a very severe ischemic, I think they will take care to inject, simply inject it. So we have last case right now. We only performed very aggressive neovascular activity case. We prefer use the injection, the bevacizumab, only the bevacizumab, just 3 days before the surgery.
okay.
Yeah.
So I'll show you one of the things that I started doing 2-3 years back when we had the dexamethasone implant. So I thought that we can avoid some of the complications. I was using even Macular before. We don't have Macular now. And here it can inhibit some VEGF, not as good as Avastin and Lucentis and so on. It can inhibit some, but we have very flexible planning in patients that are very sick. And also I felt that it helps with the dissection. I mean, this is one of the very bad cases where the proliferation is going all the way to the periphery. But look at the this is even before we go in for the procedure. See the FA and how it's consolidating all those areas. And then it's interesting that sometimes when you work on the posterior portions posteriorly, it can jump into the probe. So I try to move it to the periphery before that step. But one of the things that I really noticed, and here it using just by manual dissection with the vertical scissor and the forceps, is that when I inject Avastin, it makes the fibrovascular tissue very adherent to the surface of the retina and more difficult to dissect. With the steroid, because it acts on different cytokines, I still maintain that space. So I feel that anytime I go for the procedure, my dissection is not as difficult as in response to inhibiting VEGF alone. And this is nice, is that the peak effect is at 2 months. Whenever they get cleared or they come for the procedure, I did it at 2 weeks, 1 month, 2 months. As long as it's in the eye, then...
So do you think it often makes sense to inject the triamcinolone before the surgery?
Yeah, so
Triamcinolone down.
it's very similar to any steroid. The advantage is that I don't know when I'm going in for the procedure. And I like that it's producing the same amount of steroid being released inside the vitreous cavity every day, but also to see that at the end of the procedure, I leave it in the eye and it continues releasing in the eye. But one of the things that because Yusuke, you're the pioneer of the 27 gauge, and we were talking about mix. So this is a concept that we developed about mixing gauges. So we really know the advantage of the 27 gauge probe. The problem is that in a case like this, where the proliferation is very peripheral, it's very difficult to work with the 27 in the periphery, and there is limited motion. But if you put 27 through the 23 gauge cannula, you may be able to reach and use it. So our fellow Scott Walter worked with me in the lab with this. We had 27 through 27 and 27 through 23. And you can cover 23% more of the surface area of the retina if you put the 27 through the 23. So this is an example of those cases, and you can see the size of the probe 27 compared to the light pipe. that is 23. And then we're doing the anteroposterior dissection, and then here I can do all my segmentation in the periphery because I'm going through the 23 gauge cannula without bending. But I'm also using the advantage of the 23 system with a diffusion light pipe. I have valved system, so I'm not losing any outflow inside the eye. But also I'm very efficient working in the periphery because of the bimanual work in the periphery. But I also can go back and use my vertical scissor, which is 23 gauge. And here we're kicking in with the intraoperative OCT, B-scan, C-scan, and intraoperative imaging, and we can see exactly where we are. Even here in the periphery with the vertical scissor and the forceps, we can still see it on the OCT. We can see the Ozurdex, and we can also see the tips of the vertical scissors in the pre-retinal space. And this is what I like to see post-op. Here with oil, you can see the implant in the aqueous phase, and the eye is very quiet, and it continues releasing inside the eye. So I've been trying to do many of those routinely for now. I mean, what do you think, Yusuke? I mean, because you're the pioneer of 27. I mean, have you tried mixing, or do you stick to 27?
No, I never use as a hybrid type of surgery, but in a very severe case, as you talked, we cannot reach into a soft peripheral area, even with the 27 gauge. So at the time, I still prefer use the 25 gauge to that. It's a very neutral. You can do. You can use the 25. You have just like the advantage of both 23 and 27, I think. So I usually the challenge has use 25 gauge system.
Great. We're going to move to a complication that we see very often. So this is a patient that is diabetic, had old diabetic vitreous heme, and here we're going in and we're trying to remove the heme, but I suddenly find out that the probe is not moving. The probe is stuck within the cannula. So what should we do now?
In that case, I think we should no longer pull it off so strong. Otherwise, may encounter giant tear. So keep it this. This case, basically, I prefer to use the one. I need to take a new cutter to insert the opposite side to shaping around the
that cutter.
Yeah, otherwise you cannot move it because the vitreous is already stuck to the cannula.
Yes.
So we need to use the counter side to pushing it a little bit, and then use the new cutter to cutting off the incarcerated vitreous, and then we can gently move it, the cutter.
Carlos, what do you do?
I think in these severe old hemorrhages, the best thing in the beginning is try to remove around your vitreous tip all the vitreous you can, as to trying to avoid this.
Yes.
But I had one time that I had to use another cutter, just to press with the other hand a light pipe there, and then to clean the vitreous tip.
And here I try, see, even when I took the cannula outside the eye, and you can see that you cannot move it. I mean, it's totally stuck inside the cannula. And then we open it and then try to put the cannula back in place. And these are valved system, and then you go in, and what do we see? We see the break.
Yeah.
So 100% in all those cases, and this is a case even when we didn't have the valved system. So I thought if I have more outflow, but if you have the same gauge, you're stuck exactly the same way. I mean, it's a great option. This is a new trick that we can do. One of the things, like if I have those cases and I go in and I know that this is an old vitreous heme, I know I'm gonna stuck every time. So one of the options that I use is also the mixing the gauges, putting a 27 through 23, or chew the valve with a 23 so I have more outflow, or even open it with a 20 or 20 gauge MVR and have more outflow.
Yeah.
We didn't have it before. Now we have this with the cannulas.
So my big caution, not only the 23, even the 27 gauge, I encounter the same complication. Even the very small cannula,
Yes.
yeah, it still have the same situation.
Yeah.
So there's no way to avoid if we use the trocal cannula. So that is why when the very dense vitreous case, you make to keep in mind we may encounter such a situation. So before insert the cutter, not insert too deeper. Insert it a little bit and gently still starting to cutting off the dense vitreous around the cannula to avoid such incarceration.
To avoid the incarceration. Now we're going to move to an interesting topic, macular folds, and we have all seen those cases. This is a patient that was done outside with a superior detachment, comes to me with that macular fold, 2160 vision. So what would you do, Carlos?
In this case, I would operate this case because it seems that the foveal fold affects the foveal area. I think you have to distinguish between cases that have the fovea affected or the fovea non-affected, because some of these folds, the fovea is not affected, and the fold disappears over time, and the patient recovers a certain vision.
And there are, we're going to show your technique now about to do it, but I decided that day not to do anything. I said, let's wait. There is still a chance we can go in. It's only 2 weeks. And then she comes back in a month, 20/50 vision. It looks a little bit better. And then 5 months, she's 20/30. You don't see the area of the fold. So I was lucky in this case. The problem is that there is no way to predict. So she's 20/30, she's not the happy 20/30. She still feels a difference. Now I wouldn't do anything, but is there a way to predict which one you want to go in and unfold or which one to observe? Any tricks or any ideas?
When I see that the fovea is affected by the fall, I enter in the eye.
You go in the same week? Or
I try to go in the first week, 10 days.
so let's see. Hold on. So this is one of the susceptibility when we can get macular folds, but let's go through your case.
But this is a very strange macular fall because, you know, as you can see, the inferior retina is over the superior retina. Then they operated the patient and maintained prone position during the hours after surgery. Where I started, not in the fall because the fluid can go to the periphery, and be careful the fovea, because the fovea is the thinner part of the retina, then you can promote a macular hole. Then I go to the mid periphery, I create, this is in 20 cases, this is all macular fold. They have other cases, but you know, I inject in the mid periphery trying to obtain 2 bubbles of fluid. Then I go under air, and these bubbles of fluid go down, and then you make this bubble to, you know, to join the posterior pole. You have to be, you know, sure that you are detaching the macular area, because you won't move the fold. Then with this, you know, soft tip cannula, I move the retina very soft. This is the most dangerous maneuver during this technique. And then you are sure that you are detached. You have detached the macula, and then perform carbon liquid. As you can see here, you are opening the fold. This is, I stain. I always remove the internal limiting membrane in this case, because the internal limiting membrane can maintain this, you know, irregularity in the internal retina, and the end fluid exchange. I remove the fluid from the periphery. At the end, this patient ended at 2032, I think, vision. Okay, this is another one. This is very tiny fall, and I agree that perhaps this tiny fall, but it was 0.1 vision only, and was just near in the center. And then I stained before of the beginning to detach the retina. Then I began to induce these 2 bubbles of fluid under the retina. As you can see, some air entering the subretinal space. This is not good. And then after you detach the macular area, I put perfluorocarbon liquid. And then you will see an image where the folds open are not marked by the dye. As you can see here, there are lines, white lines that were inside the folds. And then we always, as I told you before, there is no science, you know, behind this, because you know no one has published this. And but I always try to remove the internal limiting membrane, and then I remove the fluid from the periphery. I do laser and fluid exchange. In 2 weeks, this patient went to 0.7 vision. The picture there against the picture there was a different 6 lines of vision. Then, you know, in this case, I decided, perhaps in this case, as you mentioned, perhaps waiting, you know, 1 month could improve. I don't know.
Well, it's great that you mentioned also the trick of the ILM, because you know, I've done it before. I heard from many surgeons is that it becomes inelastic, and it leaves. It can affect even the fold. So always in those cases, peel ILM. Any tips from you, Yusuke? Or?
Perform the ILM peeling, but I peel the ILM just starting the surgery, not underneath the peripheral, because this time it's a very flattened retina. It's not detached retina, so peel off the ILM much easier to under the full field eye. And they also perform just like the artificial detachment, but not so wider, just up to the equator. They perform the fluid exchange. You can push down the subretinal fluid to the macular area. I think we can flatten, can create the dome-like the detachment. And I like to use the locking, just light locking technique to shaking the eyeball. Then we can make it much more fragile and move out the retina. Then they perform the fluid exchange.
Great. So one of the things we talked about retinal folds, but also we try to avoid retinal folds. The best way is that a lot of patients don't put their patients face down. So that's the key, to try to avoid it instead of dealing with it. But one thing that we're seeing more in the clinic nowadays is also slight displacement, not macular fold. And this is a patient that came, you can see the posterior was done outside, it was a posterior retinotomy. But you look at the blood vessels here, how this is shifted like almost a translocation. And it's really much easier to see those with red-free, you know, here, and autofluorescence. So you can look at it and you can see exactly the areas where the old blood vessels were and how it is moved inferiorly. And it always comes to my mind, a lot of people in private practice in an ASC they don't use PFC. They use just quick fluid air exchange. I think it's much lower with PFC, but I'm seeing those more and more, and especially patients that have really good outcomes and vision, they get really disturbed by this. Have you seen it? Any tips, any tricks about?
I still keep the face down, the flattened, the face down position very restricted immediately after surgery. So in my practice, I do the older case, the day surgery. We don't have the bed. So after do the surgery, I let them our office keep the the position for about 30 minutes, and then let them to go back to home. So this is our only technique to avoid this one. But I'm not sure. I'm not encounter surgery severe displacement like here.
Well, Carlos, do you think using PFC to fix the detachment prevents some of
I think
the
this kind of posterior retinotomy to remove the fluid is not so, it's not so brilliant idea to remove the fluid. It will maintain a lot of fluid under the retina and the posterior pole. I think the key point, even in the folds, is the same. In the folds you have to avoid to have a substantial subretinal fluid. Then any effort to reduce the subretinal fluid under the retina, it will increase your success rate. You didn't to decrease this. And then, for example, I do different. I do perfluorocarbon liquid near the break, and I put air, and I work under air. I do my peripheral vitrectomy under air, and then you are making the what I call sandwich technique. I put perfluorocarbon liquid, air, perfluorocarbon liquid, air, and all the fluid are there. And then you are aspirating, you sucking. You never remove all subretinal fluid. And then at the end, when the patient goes outside from the OR, I put the patient from the side. Yes, to remove all the fluid on the macula to the side. Or if the brakes are down, I put seated, or if it's, I do, steam roller, try to remove the fluid from the macular area.
So we're going to end with an RD PVR case from Yusuke. Go ahead.
All right, this is a very challenging case of a severe PVR. Again, the most similar to the diabetic case, we right now use the chandelier. We can do the manual technique. So key point in this case is how to separate the membrane and create the induction, the PVD to the far peripheral area. So again, you can see the cutter. We can use it just like the forceps or the spatula to separate the membrane from the retina. And in the case, I use peripheral carbon to flatten the retina. Again, I also like to make sure how wider we can create a completed vitreal detachment. And use the wide angle system, you can see we can use biomarker technique very easy to separate the membrane again here. Of course, this case, I also prefer to perform the membrane peeling around the macular area, and also remove the peel together with the ILM, because this case, after PVR case, sometimes you encounter the reproliferation. So remove the scaffold is very important. I can see how far peripheral we're reaching to, and also you need to make sure we completely extended the flattened retina. Otherwise, still find out some the subretinal strand we need to remove. But once used under the ear, we can flatten retina. Even just some strand under the retina, we don't need to remove it. We don't need to beat it.
So as soon as I looked at that video, initially with the view and the hyaloid and how the retina's detached, it looked chronic, a little bit detachment. And I was waiting for a retinectomy, a large retinectomy, but you didn't need a retinectomy.
In this case, I'm very lucky we can flatten it. Without flattened retina, I think about retinectomy. But if it's the case, we cannot complete the PVD to the peripheral area. My first choice is still choose use the buckle, much wide band buckle, to encircling buckle to support the peripheral area, and then to find out some portion to need to perform the retinectomy. But retinectomy, it's a very, very tricky technique. Once you cannot attach retina, we encounter much severe PVR again, come back to the operating room. So we need to avoid to do the retinectomy so easily. So we need to make sure how wide we already create the PVD, and how much of the wide angle we can remove the membrane. And you still have a very severe area with the contraction. We have no way but to perform the retinectomy.
So I would like to thank everyone for being here. I would like to thank Dr. Yusuke Yoshima from Osaka, Japan, and Dr. Carlos Mateo from Barcelona, Spain. And thank you all for coming to the Duke Eye Center booth.